Sir, you can start.
Good morning, friends. Welcome to IAC webinar. Myself, Dr. Ketan K. Mehta, Honorary General Secretary of Indian Society of Electrocardiology, welcome you for this webinar for common cardiology care for clinicians. Friends, as all of you are aware, we have been doing webinars regularly, periodically under the banner of Indian Society of Electrocardiology, and we had done a lot of these programs under the guidance of our patron, Dr. S.B. Gupta, our president, Dr. Bhagwat, myself, and our treasurer, Dr. Ashish Nabar. Friends, now we have gone a one step ahead. We have got, for the first time, accreditation for the modules which we are going to have it from today. So this is a Maharashtra Medical Council accreditation. Each program will have 1 credit hours, and we are going to have this program in all 4 Sundays of November. Of course, the middle 15th November is the Diwali holiday, so we will have spread over 4 Sundays. We are going to have from 11 o'clock to 1:30. It's not 1 o'clock, it will be 1:30. The first part today is we are having is diagnosis of ischemic heart disease. The second part on 8th November, we will have diagnostic modalities in cardiology. Third part we are having is on 22nd November is on hypertension, and the fourth part 29th November, last but not the least, which is a very important topic again, are cardiology in pregnancy. Again, this time we have gone a different module. We are going to have an interactive ECG quiz in each module, and we have a quiz master for all these modules. So I'm sure this is going to add really value to your clinical practice. So friends, without wasting much time, I would start with today's first talk, that is going to be a diagnosis of ischemic heart disease in various modalities. And to take the proceedings further, may I invite our moderator for today, Professor Dr. G.R. Kane, who is the professor who is and head of Department of Cardiology at D.Y. Patil Medical College. He is the consultant cardiologist at PD Hinduja National Hospital, S.R. Mehta Hospital, Nanavati Hospital, and Bridge Candy Hospital. He's been the chief coordinator for National Coronary Intervention. He has been on the Registry of Cardiological Society of India for 1999 to 2001. He was the ex-professor and head of Department of Cardiology at LTMG, popularly known as Sion Hospital. He has also been a member Credential Committee of CSI, member Editorial Advisory Board of Indian Heart Journal. He's been an examiner for DM Cardiology for University of Mumbai. He has been a past president of CSI Mumbai chapter. He was the ex-honorary secretary of Indian Society of Electrocardiology, under which banner which we are doing it, and he has also been a past president of IAC. So it is my honor and privilege to welcome Kane sir, and he will take the proceedings further. Friends, first we are going to have these 3 sessions, followed by there is going to be a panel discussion. You can put your questions in the chat box, which would be there over in your screen. You can put your questions, which will be answered by our eminent team of panelists at the end of this session. And finally, we are going to have the ECG quiz. So thank you so much, and over to Dr. Kane, sir. Thank you.
Thanks, Ketan. Good morning, everybody. I'm sure we are going to have a good time today because the topic is good, and we have a following which a very interesting quiz by one of our esteemed professors, Dr. Dwivedi. So my job is to conduct the first part of the program, and the first part of the program is, as you know, diagnosis of ischemic heart disease. So it's an interesting topic because the first step in managing any ischemic heart disease is making the diagnosis. And we will have 3 talks under this category. The first one being by Dr. S.B. Gupta on role of stress test. Dr. Gupta is a very good friend. He's a consulting physician and cardiologist in Mumbai, former head of Department of Medicine and Cardiology at Railway Headquarters Hospital, Baikala, Mumbai, past Dean, Indian College of Physicians, and past President, Association of Physicians, past International Governor, American College of Chest Physicians, So his accolades can go on and on and on. Dr. Gupta has played a very, very important role in giving educational fare to most of us throughout his career. And I will say it will be an overstatement if I say that without Gupta, we could hardly conduct any of our proceedings for a long, long time. So Dr. Gupta has been a very, very important part of our organizations here. And I'll invite him now to give his talk on role of stress test in diagnosis of ischemic heart disease. Dr. Gupta, please.
Thank you, Dr. Kane, for your introduction. And I'll just share. Is my slides visible?
Yes.
So the talk is for the role of stress testing in coronary artery disease. I think a lot of people may say that the stress testing or stress ECG testing, or the popularly called as treadmill test, is obsolete now. But I feel if the test is done properly and interpreted properly, it can give a lot of valuable information as far as coronary artery disease is concerned. A meta-analysis of 147 studies over about 24,000 patients. The mean sensitivity of the test is around 68%, and it can range from 23% to 100%. And the mean specificity of the test is 77%, again ranging from 17% to 100%. So on the positive note, if you see that the test can be as sensitive as 100% if we take the criteria properly, or the test can be 100% specific, again, if they take the criteria as needed. Normally, when we do, I think a lot of people just report the stress test on just one criteria, that is the horizontal or down sloping ST segment depression of equal or more than 1 millimeter at 80 milliseconds after J point. This is the criteria which has been laid down for stress testing positivity. And people go by this criteria alone, and they just make the test positive or negative based on this criteria. But I think one has to go beyond this criteria to more specific, whether the test is strongly positive, or rather we try to risk stratify the stress test and give more information once we interpret the stress ECG test. I think it's very important to take the history of the patient before we do the stress test, and we shall try to find out whether the patient has got a non-cardiac chest pain. You might have noticed the patient, they do just complain a vague chest pain on the left side or the right side of the chest, and which is not exertion related. It comes like a pricking pain lasting for a few seconds. It may not be a cardiac chest pain. Or patient may have an atypical angina where you are not sure whether the patient is complaining of the chest pain, whether it's really non-cardiac chest pain, or it could be angina. So it's like atypical angina, or where the patient complains of typical angina, where the patient says that he gets chest pain whenever he walks for 100 or 200 meters. If he takes rest, then the pain is relieved. And again, when he walks again, then pain comes. This is typical angina. So we have to take this history. I think it's very important for interpretation of stress test. And I have always said that exercise ECG testing is an art and science. Art is how you do the test, and science is how you interpret the test. So doing a test and interpreting the test, if we do it properly, then we can give valuable information to the patient, to the referring clinician about the stress ECG test. When we are doing the test, I think it's very important to condition the patient. Patient must, if possible, he should know how to exercise properly, so that when he is doing the stress ECG testing, he should walk on the treadmill for a sufficient duration of the time. Patient should be prepared properly, because if the ECG electrodes, etc., are not put properly, it can give a lot of artifacts. We should demonstrate how to do a stress test to each and every patient, so that he knows how to walk on a treadmill, because sometimes people are very difficult. They do not walk properly, so proper demonstration. Patients should always be motivated to walk on a treadmill to attain at least 85% of the target heart rate. If we can achieve 100% of the target heart rate, it's much the better. We shall assess the symptoms and signs during the course of treadmill test or stress ECG testing. Then comes how to interpret the ECG. We should know certain computer wizards, especially the artifacts. And I think the most important person is again the interpreter who interprets the ECG test and try to find out whether the stress test is negative or positive, or it could be a false negative or false positive, and how to risk stratify the stress ECG test. Now we should know that the test can be false positive, especially in females. The test is almost maybe 30% time it may be a false positive stress test. If there are resting ST segment abnormalities, if there is an LVH, if there is an LBBB, RBBB, or P-excitation syndrome, if the patient is suffering from mitral valve prolapse, or the person is on digoxin, the test can be false positive. Similarly, the test can be false positive. Person is having severe hypertension, severe aortic stenosis, or if he is having cardiomyopathy, anemia. I have seen a lady with people have not checked the hemoglobin. Hemoglobin was around 7.5. Did that stress test positive, but it was a false positive stress test because she went for a coronary angiography, which was normal. If the hypokalemia, severe hypoxia, sudden severe exercise, severe hyperglycemia, hyperventilation, severe volume overload, or in supraventricular tachycardia, the test can be false positive. If the test is false positive, it does not mean the patient does not have a coronary artery disease, because his epicardial coronaries are normal, but he may be having abnormal coronary vasodilator reserve, or he may be having abnormal LV systolic and diastolic function. That could be the cause for the false positive stress test. Similarly, the test can be false negative if the person is having a single vessel disease. Suppose if he's having just a circumflex disease, maybe in mid or distal circumflex disease, it could be a false patient. He's having coronary artery disease, but the test may be negative. Similarly, in double or triple vessel disease, even in triple vessel disease, the test may be in about 10 to 15% time, it may be negative. So we should always be sure whether the test can be false negative even in triple vessel disease. If the patient is on beta blockers or on vasodilators, the test again can be a false negative test. So can we increase the sensitivity and the specificity of the test? I think that's the most important thing. I think if we take a pre-test probability of coronary artery disease by age, gender, and symptoms, we know the test probability. I have told you, if we take a proper history, if the patient is having a typical or definite angina pectoris, and if the test is done at a younger age, it has got an intermediate test probability. But as the age advances, for the men, it is always a high probability the person is having a typical angina. For females, it has got an intermediate test probability between 40 to 60 years of age, and from 60 to 70 years of age, it's a high probability. And the probability goes down if the person is having atypical angina pectoris, or if a patient is having a non-anginal chest pain, then the test probability is low. But still in men, it has got an intermediate test probability even from the age of 40 years, if even the patient is having non-anginal chest pain. But however, if the patient is asymptomatic, the test probability is very low, low to very low. If we want to increase the sensitivity or specificity of the test, we can always use Duke treadmill score, which does not take only the ST segment deviation, but it takes into the consideration how much time the patient has walked, the exercise time in minutes. What is the ST segment depression, whether it's 1 millimeter or more than 1 millimeter, and whether the patient is having treadmill angina. If there is no chest pain, then we give the score of 0. If there is a atypical angina or non-limiting angina, then we give score of 1. And if patient has got limiting angina, then we give the score of 2. And it is exercise time in minutes, 5 into ST segment deviation, and 4 into treadmill angina. And then we try to risk stratify the stress test by into low risk, moderate risk, or high risk, depending upon the score achieved. I think this is a very important slide where where I want to tell you about the risk stratification. I have told you about the pre-test probability, the workload. If the patient has walked only for stage 1 of Bruce protocol, that is less than 4 minutes. That is the workload. If the patient becomes positive in stage 1 of the Bruce protocol, and then it seems to be higher risk. At the pressure load, that is BP into HR rate product, if it is more than 80,400, then it's a good pressure load. But if the patient becomes positive at less than 18,400 BP HR product, then the prognosis of the test is poor. The number of leads, if the more number of leads, if it's more than 5 leads or more, then the test is again strongly positive. The quantity of ST segment depression or ST segment elevation, if it is more than 2 millimeter ST segment depression, then again it's likely to be strongly positive stress test. If there's a delayed recovery, more than 7 minutes, if the patient has not recovered, again the test could be strongly positive. If patient has got limiting angina, if the patient developed complex ectopies and ventricular ectopies, like triplets or couplets or multifocal arrhythmias, more on during recovery, then again it may suggest a severe coronary artery disease. And if there is a fall in blood pressure, again it may suggest severe coronary artery disease. So it's not only the ST segment depression, but if we take these things into the consideration while seeing the stress test, I think we can give more information regarding the stress test. There have been a lot of controversial criteria. I'll not go into these controversial criteria because they have not stood the test of the time. So these are a lot of criteria have been talked about. I think just a simple like heart rate response, if there is an excessive rapid rise, suppose the patient achieves 100% target heart rate in stage 1 of the Bruce protocol. It could be either the patient is not conditioned properly because of he has not exercised properly, or patient may be having a severe coronary artery disease, though test may be negative, but still the patient may be having coronary artery disease. There is an excessive rapid rise of the heart rate. If there is chronotropic incompetence, again it may suggest significant organic heart disease, or patient may be having 6-sinus syndrome. If the rate of slowing of the heart rate during recovery is less than 12 beats per minute, again it has poor prognosis. And this is what we have seen in our stress test lab, that sudden slowing of heart rate and immediate recovery, then gradual rise is suggestive of right coronary artery disease or left circumflex disease. This is what we have published in also JACC long back. And then the BP response, if there is a failure or poor rise in blood pressure, again it suggests the severe coronary artery disease. Or if there is an abnormal fall in blood pressure, again it may suggest a severe coronary artery disease. If there is an abnormal rise in exercise systolic blood pressure of more than 215 millimeter of mercury, with normal resting blood pressure, it tells about the increased risk of future sustained hypertension. And if there is a retarded drop of blood pressure during post-exercise period, it is again an indicator of ischemia. So I think it's very important to see heart rate and BP response also. It's one study of BP response, systolic blood pressure greater than 190 millimeter of mercury at 2 minutes recovery. There is a 1.7-fold increased risk of MI in such patients. And each 10 millimeter increase from 195, there is 7% increased risk of MI. So retarded drop of blood pressure is again suggestive of coronary artery disease. We have talked about ST segment depression, but during exercise, if patient develops ST segment elevation, which is though very less, 0.2 to 1.7%, but it has got a very good correlation with culprit vessel localization. If the ST segment depression is elevation is there in anterior leads, especially in V2, V3, it suggests a severe LAD disease. If it is there in lead 2, 3, and AVF, it suggests a severe proximal right coronary artery disease. If the ST elevation is there in V1 or AVR, it may suggest left anterior descending artery. And if the ST segment elevation is there in V1, it rules out RC or circumflex. But in the ST segment elevation is there in AVR, it may also happen in right coronary artery disease or circumflex disease. So one should also see the ST segment elevation, not only the ST segment depression, but ST segment elevation. And these are the few stress tests which we have done. And you are seeing the ST segment depression in AVR alone. There is no ST segment elevation in AVR or AVL or in V1. So ST segment elevation in AVR alone. This is one more exercise test where you are seeing an ST segment elevation in AVR, AVL, and V1. So the probability of LAD disease in such a stress test is quite high. There's one more stress test where you are seeing a marked ST segment elevation in AVR as well as in V1. Again, and quite a severe or strongly positive stress test. So it may suggest that the patient is having a proximal LAD involvement. We are just talking of a ST segment depression of less than 1 millimeter. And when patient is having upsloping ST segment depression, sometimes people say it's upsloping ST segment depression, which is the test is negative. But if there is upsloping ST segment depression of more than 1.5 millimeter at 80 milliseconds after the J point, it's again a reasonable criteria for a positive response. If the patient developed ventricular arrhythmias during the stress test, again, if the patient develop ventricular premature beats and ST segment changes both, then the annual coronary event rate is almost 11% as compared to if the patient had no ST changes or no VPBs, where the annual coronary event was 1.7%. If there was just a VPBs alone, then the annual coronary event was 6.4%. So if the patient is having both ventricular premature beats and ST changes, the annual coronary event rate is pretty high. Similarly, the 12-month mortality is 3 times greater in persons exhibiting exercise-induced ectopy, and mortality with complex ectopy is exceeds than those for simple ectopy. And if the patient who are already on antiarrhythmic therapy and they develop sustained exercise-induced ventricular tachycardia, there is a very high risk of sudden cardiac death. We should also know that the VPVs, whether they are appearing during exercise or during recovery or both, have got a lot of prognostic significance, because after cessation of exercise, the parasympathetic tone should be reactivated quickly and should suppress the catecholaminergic ventricular ectopy. And if the VPVs persist after exercise, it's a marker of attenuated vagal reactivation with a lot of prognostic significance. And this study has shown that VPBs after exercise, where more than 30,000 patients, almost follow-up period of more than 5 years, 1862 patients died. And the patient who developed VPBs during recovery after exercise, there was an increased risk of all-cause mortality, and the hazard ratio was almost 2.4. So this is one graph which is showing if there is no ventricular ectopy with the stress test, the survival is far, far better. If the ventricular ectopy developed during exercise, the survival is poorer. If the ventricular ectopy developed during recovery, the survival is much less. And if the ventricular ectopy developed during recovery and during exercise, then the survival is far, far less as compared to the previous 3 categories. If the patient has got right bundle branch block and if he complains of chest pain, whether we can do exercise stress test? Yes, we can very well do the exercise stress test. And the presence of right bundle branch block does not appear to reduce the sensitivity, specificity, or the predictive value of the stress test for the diagnosis of ischemia. However, we should know if the patient has got right bundle branch block and if he develops ST segment depression from V1 to V3 alone, then it is likely to be a false positive stress test because of the right bundle branch block. But if he develops ST segment depression in lateral leads like V5, V6, or in inferior leads, then it is a true positive stress test in the presence of right bundle branch block. These are one patient who has got a right bundle branch block and during stress test, he developed ST segment depression, but the ST segment depression is there in V1, V2, V3 alone. There are no ST segment depression in inferior leads or in the lateral leads. So this is a false positive stress test in presence of right bundle branch block. There's another patient who has got right bundle branch block and he develops ST segment depression in V2, V3 as well as in lateral leads, V4, V5, V6, and as well as inferior leads. And the same ST segment depression becomes more prominent in the lateral leads as well as in the inferior leads. So this is the true positive stress test in presence of right bundle branch block. Whether we can do a stress test in presence of left bundle branch block, again, left bundle branch block, the stress test is always false positive, and we cannot label the patient has got ischemia in presence of left bundle branch block, because exercise-induced ST segment depression, usually with left bundle branch block, has got no association with ischemia, because we can get even up to 10 millimeter of ST segment depression in presence of left bundle branch block. So there is no level of ST segment depression that confirms the diagnostic significance of left bundle branch block. But still, I will say that we can do a stress test in presence of left bundle branch block just to see the symptoms and signs of the patient, his effort tolerance, and if the patient, suppose with the left bundle branch block, if he can walk stage 4 of the Bruce protocol with no symptoms, he has got no drop in blood pressure, etc., then the test is likely to be negative in presence of left bundle branch block. And patient may develop exercise-induced left bundle branch block, which is associated with 3 times high risk of death and major cardiac events. And this is again exercise-induced left bundle branch block. If a patient develops exercise-induced left bundle branch block in presence of structural heart disease, then the pooled mortality is almost 2.7% as compared to if the patient developed exercise-induced left bundle branch block with no structural heart disease, where the pooled mortality is just 0.2%. So this is one patient who has gone a stress test with left bundle branch block, and even you can see the exercise time is 11.50. That is stage 4 of the Bruce protocol. And though the stress test is seems to be positive, it's a false positive stress test. But though patient did not have any symptoms or a fall in blood pressure, so likely this is a negative stress test. So this computerized treadmill test is useful in various cardiovascular disease. Other than evaluation of coronary artery disease, we can do CTMT in rheumatic heart disease, in valvular heart disease, post-CABG, post-PTCA. So it's not just the evaluation of coronary artery disease. It has got a lot of where we can do the CTMT. And I have told you in the beginning that we shall not only tell that test is positive or negative, we shall always try to risk stratify the coronary artery disease, whether the person has got high risk positive or intermediate risk or low risk. If it is a high risk, then the patient should go for a coronary angiography, and maybe he would need a revascularization. If the test is of intermediate risk, then we may require further imaging, or then depending upon like whether patient needs a stress echocardiography or patient needs a CT coronary angiography, and depending upon the results, whether the patient needs the revascularization. And if the patient has got a low risk category, then maybe we can just send the patient for medical management. I think before I end my talk, I would like to mention 2 more things. One thing is when you are doing a stress test, I think you should always be prepared in your stress test to deal with any event or any event, which serious event which can happen. So your stress test should have always the endotracheal tube, and you can intubate the patient if need be, or we should have a defibrillator in our stress test, because we have saved a few patients who developed serious arrhythmias or even developed ventricular fibrillation, and we have reverted them and saved their lives. So one thing is that's very important to keep the equipments to resuscitate the patient in case of any eventful. And the other thing is whenever you are telling about the positive or negativity of the stress test to a patient, be always cautious because of the legal implication. Or if the test is negative, you can always tell the patient though the test is negative, but it's still it's just 85% the test is negative, but it's still 15% we can miss the disease. And if there is any doubt, then the patient should be subjected for maybe for CT coronary angiography. Similarly, if the test is positive, you try to identify whether the test is false positive or true positive, and accordingly tell the patient. So I think that's also very important. With that, I thank you all for patient listening. Thank you very much.
Yeah. So thanks, Dr. Gupta, for an excellent lecture on stress testing. I think you covered almost everything under the sun as far as stress testing is concerned. And we are going to take the questions at last. So I'll introduce the next speaker. Next speaker.
Thank you, Dr. Kante. Thank you.
Yeah, he's a good friend. He's my teacher, and he's none other than Dr. Darshan Jhala. He's from KEM Hospital. He was a lecturer when I joined to do cardiology at KEM. He's in practice for over 35 years, performs all sorts of procedures. He is a wizard, according to me, because his knowledge of cardiology is supreme, but his knowledge overall in all aspects of life is itself, only you have to come in touch with him to know what is Dr. Jhala. Only then you will know him. So I owe a lot to him, and he's attached at the moment to Lilavati, Nanavati, and BSCS, and is the principal investigator in RELY study of Dabigatran. And today he is going to concentrate on teaching us what is the role of echocardiography in diagnosis of ischemic heart disease. Jhala, let's start from you. Thank you.
Thank you very much, Dr. Kane, and you told me certain things about me which I didn't know myself.
You will not know them.
Yeah, so Dr. Gupta has laid down the foundation for using simple methods to diagnose a complex multifactorial disease like ischemic heart disease. So I will just be going a little further on that, and I'll be describing another test which is not probably as simple as stress test, but is now easily available even in rural areas as well, and is accessible. We don't need very, very sophisticated equipment, and it gives a good yield in diagnosing the presence, absence, severity of ischemic heart disease. I'm referring to echocardiography. And let me start sharing my screen. Okay, I hope you can see my slides.
Yes.
All right. Okay. So the role of echocardiography, I'm going to talk on standard two-dimensional echocardiography with the Doppler studies in the diagnosis and management of ischemic heart disease. So, okay, we also have now in fair number of institutes a 3D echo available, but 3D echo still has not caught up too much. So we will concentrate mainly on two-dimensional and Doppler studies. It is one of the most popular diagnostic techniques to rule out ischemic heart disease, valvular heart disease, or any other type of structural heart disease. It helps in implementing early reperfusion strategies because you can make an early diagnosis of ischemia. And we all know that in terms of ischemia, time is money and time is muscle. So the earlier you diagnose, the greater amount of muscle that you can save. This is where echocardiography is very important. So let's see where echocardiography can be used in our clinical situations. You can use it for diagnosis of ischemic heart disease. And there are generally two areas which we are always interested. One is the acute coronary syndromes, and the second one, which is now renamed as, which was called stable angina, which has now been called chronic coronary artery disease or chronic coronary syndrome, CCS. So in both these, it is important to use echocardiography wisely, because if you randomly use echocardiography, you may be disappointed and you will not get the required answers. So let's define where echocardiography is important, is useful, how it is useful, and how it should be interpreted. So you can use echocardiography as a triaging method, like we use TROP-T, we use BMP, we use CKMB, and various other markers as in the emergency room. In the emergency room, once you have triaged it and found it to be ischemic heart disease, it will help you in aiding the treatment of, in deciding the treatment modality. Now, one would wonder that if you have ischemic heart disease, angina coming to emergency room, why do you need to decide the treatment modality? Straight, patient has come with unstable angina, send him straight for angiography and be done with it. Well, the last 8 months have taught us a lot of things. We are in COVID era, and in COVID era, we are highly reluctant to take low risk ischemic heart disease patients. Unfortunately, amount of angina does not predict the amount of coronary artery disease. You can have severe angina with a very minor disease, and you have probably no angina with left main disease. So that is why we need other modalities to tell us how severe is this disease, so that in this COVID era, we can risk stratify and decide our and use our resources wisely, so that we only take high risk patients who are at higher chance of death or complications, and screen out those who are at a low risk and give them conservative treatment. So echo has become very important in the current COVID era in differentiating high risk patients from low risk patients. Then differential diagnosis of chest pain. We know that chest pain can occur because of pericarditis, it can be because of pleurisy, or it can be because of local trauma or costochondritis or dissecting aneurysms. So many of these you can diagnose. For example, acute pericarditis you can easily diagnose on echo. Aortic dissections, proximal aortic dissections with or without pericardial effusion can also be diagnosed on echo. And that is why it's a very important modality in differentiating various types of chest pain syndromes. MIs can complicate with acute mitral regurgitation, or they can have ventricular septal ruptures, easily seen on echo. In fact, the best modality to see these things. Following an MI, what is the amount of residual myocardium, whether that is viable or not, and whether patient needs anything like a defibrillator is generally decided on echo. In chronic coronary artery disease, we use dobutamine stress echo for diagnosis and quantification. We can do a serial intervention with a dobutamine stress echo or something to decide about outcomes of interventions. You do a coronary angioplasty, the EF improves, you're happy that something good was done. And following an MI, like I said, we can decide about device therapy like CRT or cardiac resynchronization therapy or defibrillator therapy based on the echo diagnosis. So it's a very important tool in both in acute coronary syndromes and chronic coronary artery disease. So let's look at this. Why is echo so given so much importance in diagnosis of acute coronary syndromes? Now, the experimental model of ischemia in the laboratory is angioplasty. When you are inflating the balloon, you are actually causing acute ischemia. So a lot of studies were done once angioplasty became popular. People studied the effect of angioplasty balloon inflation on echocardiography, chest pain, and markers, and ECG. So they found that the earliest change to occur when you occlude the coronary is diastolic dysfunction followed by loss of systolic thickening. So echocardiographic changes are the first to appear, and they appear even before symptoms and even before ST changes occur. So you get typical regional wall motion abnormalities way before the onset of symptoms or STT changes. So it's one of the most important early diagnostic methods to differentiate ischemia. Regional wall motion abnormalities can vary from hypokinesia to dyskinesia depending on the duration of ischemia and the amount of ischemia. So it's a proximal disease, you can have dyskinesia. And if it's a small vessel disease, you can just have mild hypokinesia. And the severity and extent of regional wall motion decides about the degree of obstruction, the duration of obstruction, and also tells you that transmural versus non-transmural. Non-transmural occlusions that means now we don't call it non-transparent, we call it non-total occlusions, can result in minor abnormalities, while a complete flow cessation will produce significant wall motion abnormalities. So even before the symptoms and ST changes occur, echocardiographic changes occur. And they reflect the degree of obstruction, they reflect the site of obstruction, proximal versus distal, and they can tell you also whether the thrombus is occlusive or not. So this is what is called the ischemic cascade. When myocardial ischemia develops, various tests become abnormal at various stages. So if you have decreased myocardial perfusion, which is the first thing to happen when there is coronary occlusion, if you do a nuclear scan or a PET or an exercise test, these will be positive. But as you know, in an acute ischemic syndrome, we cannot do nuclear studies, we cannot do PET, we cannot do exercise test. The next comes is the metabolic changes. Again, the PET scan will pick it up. Again, PET scan is not possible to do in an acute situation. Now comes the diastolic dysfunction, which is easily picked up on echocardiography. Then within few minutes, the systolic dysfunction comes, which also can be picked up on echocardiography. Then comes the ECG chain, and last comes the chest pain. So if you look at the diastolic function and the systolic function with easy indices, you can pick up early ischemia. And this is how the ischemic cascade works. So for a clinician, knowing some diastolic parameters and systolic parameters, he can easily differentiate various kinds of chest pains and easily estimate the severity and the significance of ischemia when a patient comes to him in the emergency room. So like I said, first is the abnormal diastolic function, followed by abnormal systolic function, which is post-systolic thickening. Then there is a loss of systolic wall thickening, that is what we call hypokinesia or akinesia. And then if the coronary artery obstruction persists for approximately more than 4 hours, myocardial necrosis occurs, which can be seen on echo as thinning of the myocardium, and then finally after 7-8 days as very bright echoes, which reflect underlying fibrosis. So depending, and of course, if you have an obstruction with preserved collaterals, then these changes may not be seen at all. But it's good, because if you have a typical angina with echo being nearly normal, you know that this patient has viable myocardium, and you can probably go ahead and intervene without subjecting him to any further tests. So even a negative echo in presence of typical angina with elevated markers, for example, can give you a lot of confidence in intervention and expecting a good result after intervention. So these are some of the important clinical implications in diagnosis. For a practicing physician, please remember these facts. This will help you in deciding which patients to do an echo when you are trying to evaluate ischemic heart disease, how much importance to give to an echocardiographic report in which patient. So if you have a typical chest pain, that is like Dr. Gupta said, very, very high pre-test probability. For example, a 65-year-old male with chest pain. So he is anyway at a high risk of coronary artery disease. If such patient has no regional wall motion abnormalities, it virtually excludes IHD. Conversely, presence of new regional wall motion abnormalities in presence of typical atypical chest pain is almost diagnosis of IHD, is diagnostic of IHD. So in such patients, you may not even wait for biochemical results to appear. In the absence of ongoing ischemia, echo can be normal, even in presence of triple vessel disease. So be careful. Chronic coronary syndromes, if there is no ongoing chest pain or no signs of ischemia, echo can be normal. This does not mean that the patient does not have IHD. Yeah, normal wall motion in presence of normal ECG and without chest pain, again, does not exclude IHD. I am talking about chronic coronary syndromes. And even in unstable angina, if the patient has come within, say, a few minutes of chest pain, it may still be negative, because like you saw in the ischemic cascade, though echocardiography is the first abnormality to happen, it still takes some time, because the metabolic abnormalities become earlier. So you have to at least wait for half an hour before the echocardiographic changes will come. So very, very early chest pain, repeat the echo within say half an hour to 45 minutes. So who should get an early echo? When you have a diet-food diagnosis or when you want early detection in a suspected high risk, high pre-test probability individual. If you have hypertension, echo is one of the most important ways to differentiate cardiac versus non-cardiac. All patients of heart failure should undergo an early echocardiography. You have unexplained dyspnea, and if you have normal echo, it virtually excludes heart as the cause of dyspnea. And if you have a new onset LVP with chest pain, an abnormal echo will help you to guide you towards intervention. Who should undergo a second echo? If there is a change in clinical status of the patient, then we need to know whether the cardiac status has changed. If the chest pain recurs and if you get new wall motion abnormalities, you know that you have to intervene. And if you have a particular restrictive filling pattern in diastolic dysfunction patient, you know that the underlying damage is much more. And these patients are generally monitored with echocardiography to see whether treatment like diuretics or ARNIs will be helpful or not. So this is some of the indications where you can decide which patient to take for priority echo. Post-MI risk stratification and prognosis with echocardiography. The degree of wall motion abnormality will tell you the severity of ischemia. So more wall motion abnormalities, more severe the disease. If you have an infarcted patient and if he gets chest pain and if you see newer wall motion abnormalities coming up, you know this is called infarct extension. So either if you have put a stent, maybe the stent is getting occluded, or if you have managed conservatively, maybe thrombus is reforming, time to intervene. Versus that, if the wall motion abnormalities have remained the same and your ECG has become abnormal, it indicates infarct expansion. This generally is because of increased ventricular intracavitary pressure, and this generally has a benign prognosis. Okay, you can also decide and see what is the amount of valvular regurgitation following an MI. The more the regurgitation, more likely this patient will require intervention. Right ventricular function has an important prognostic indication. If you have a patient with LV dysfunction and normal right ventricular function, that patient is better than those who have right ventricular dysfunction. If you have a dilated LA, you know that the LV is under stress, and that is why these are the more serious patients. Diastolic dysfunctions like, for example, restrictive mitral flow pattern is a poor prognostic indicator. So between infarcts, if you have a normal or a non-restrictive mitral filling pattern, that person is better off than those who show restrictive filling pressure patterns. So within the MI also you can risk stratify. This is important for the family and the patient to understand what is the long-term prognosis that is going to be. So how do we decide about this wall motion? We have what is called a wall motion score. After the 17 myocardial segments, we give them numbers. All the normal segments are counted as 1, hypokinetic 2, akinesia 3, dyskinesia 4. So a normal person will have a score of 17 by 17. If you have an increase of score by 5, that is if it becomes 22 by 17, whether at rest or during angina or during a stress test, this indicates significant ischemia. And this will translate to something like 15% of ischemic myocardium, which you get similar reports in nuclear scan, and it will probably predict something in the range of 15 to 20% of ischemic myocardium. And so this is a significant number. And conversely, if you do something and if the score reverses, that means you have tackled an ischemic but viable myocardium, and the prognosis is going to be good. So instead of randomly naming the segments, you can actually put a number and decide how bad is the patient and how much the patient has improved. How do we assess viability, which is an important aspect in the management of ischemic heart disease? Viable myocardium should be treated. Unviable myocardium, there is no point in wasting resources like angioplasty or bypass on that. This is where echocardiography comes in. And this is where you should be aware of two particular terms called myocardial stunning and myocardial hibernation. So myocardial stunning is Suppose you have an infarct, you have an LV dysfunction, you opened the artery, but the LV did not improve. This is because the myocardium is stunned, but it is not dead. So it will recover. So there is a normal coronary flow, but the myocardium is dysfunctional. Generally means that within few hours to few weeks, the myocardial function will return. So this is one term which we keep using in echocardiography, and this happens sometimes, many times after reperfusion following an AMI. Or if you have exercise-induced ischemia, you can have transient LV dysfunction. In unstable coronary syndromes, you can have transient LV dysfunction, which is because of myocardial stunning and spontaneous recanalization of the coronary. These patients recover. Versus that, there is something called a hibernating myocardium, which is a dysfunctional myocardium, which is supplied by a critically stenosed coronary artery. So if you find a coronary angiography showing a 99% stenosis, and that part of the myocardium is not functional, you can tell the patient that once you open up this artery, this will recover. So you have a lot of confidence in recommending the revascularization procedure in such. So this is what is called hibernation. How does echo help you in guiding therapy? If you have a low wall motion abnormality score, thrombolytic therapy can be initiated without taking the patient for interventional strategies. For example, if you have wall motion abnormalities in the right coronary artery, you know that right coronary artery has a better prognosis than the LAD. So in this COVID era, where you are hesitant to take up patients directly for intervention without knowing the COVID status, echo can help you to separate the low risk patients from high risk patients. And suppose you are working in a center which does not have interventional facilities, the low risk patients can be managed by you, while you can take a decision to early transfer those patients to a PCI center so that their mortality is reduced and your stress on the non-PCI center is reduced. So echo is a very useful test which can be done even in a peripheral non-PCI center to decide between which patients to keep and which patients to let go. Also, complications following or during an MI, like an LV thrombus, which will require anticoagulation, development of LV aneurysm, pseudoaneurysm, which is like a ventricular rupture, ventricular septal rupture or infarct-related VSDs, acute mitral regurgitation. These are all complications which can be easily diagnosed based on echocardiography. A word on dobutamine stress echo. We generally do this echo, stress echo, when either as a pre-operative evaluation, for example, typically in orthopedic patients who cannot walk, and those or those who require those who are at a high risk of ischemic heart disease but require some kind of a major surgery, for example, abdominal surgery or any other organ surgery like brain surgery or whatever, or spine surgery for that matter. We do a dobutamine stress echo. We progressively infuse larger and larger doses of dobutamine, and we keep monitoring with echo, and we look for wall motion abnormalities. And we again use the wall motion score, and the significant score is a change by 5, like I said before. And whether if these revert to normal, then we know that we are dealing with a viable ischemic myocardium, and these patients should be immediately subjected to invasive studies. So this is how you interpret a dobutamine stress echo. If your tissue is normal, at resting the echo will be normal, low dose will be normal, at high dose it will be hyperkinetic and it will return to normal. If you have ischemia, at rest it is normal. Low dose, it may or may not worsen, but it will worsen. The wall motion will become worse during exercise, during peak infusion, and it will again revert back to normal. So this is ischemic viable myocardium. Now, if you have wall motion abnormalities which persist continuously, they are present at rest, there is some improvement in low dose, and then there is a deterioration at high dose, which again goes back to rest. This is viable non-ischemic myocardium. And if you have an infarcted segment, there will be no change. So you can easily distinguish viability from dobutamine stress echo and decide which patient should undergo priority for intervention. We have a new entity called myocardial contrast echo. We inject different contrasts and they get into the myocardium. And obviously where the contrast does not get in, that myocardial segment is ischemic. This is a little more advanced form of echocardiography and can be done in select centers, but is useful and it's coming up. This was described way back, and basically the picture looks like this. All this white thing is the contrast, and then the contrast fills into the myocardium. This black thing is the myocardium. So after some time, the contrast will go into the myocardium, and obviously in those segments which are not perfused properly, the contrast will not be seen versus those areas which are perfused. So you can decide the territory, you can see the extent of ischemia, and this reflects the microvascular function. And that is why if you have a good late contrast coming up, you know that this is a viable myocardium, and this gives you MRI quality images. So it's very, very good, and in select centers it is being used. It's not very expensive. And these are some of the newer techniques which we are using to display, to diagnose ischemia. This is called strain displays and strain rate analysis. And a normal strain looks like this. This is called a bullseye map. And if you have ischemia, then you can see that the strain things will become abnormal. And whatever was seen in red will become either pink, or it will become white, or it will become blue. So you can easily diagnose areas of ischemia using strain displays. But these require a little bit more advanced training and a little bit better equipment. But it's still not out of the reach of normal echocardiographic laboratories. So in strain echo, we detect early LV dysfunction, and it can differentiate between viable and scarred myocardium. So some of the new technologies, 3D echo is useful in detecting various complications. Myocardial contrast echo is important in detecting myocardial perfusion. And the strain echocardiography gives us an indication of early LV dysfunction, and we can decide interventions early on. A word about non-ischemic regional wall motion. Those who are doing echocardiography will understand that ischemia is not the only reason for abnormal wall motion abnormalities. If you have conduction diseases like left bundle branch block, you can have wall motion abnormality. If the patient is on ventricular pacing, you can have wall motion abnormalities. Frequent premature ventricular contractions can produce wall motion abnormalities. Wolff-Parkinson-White syndrome can produce abnormal contraction patterns. If you have a right ventricular abnormality, like a dilated right ventricle or a severe pulmonary hypertension, you can have septal abnormalities. Pericardial constriction is an important cause of wall motion abnormalities. Following cardiac surgery or after removal of the pericardium, and large ascites and riotous hernia can also produce abnormal wall motion abnormalities. So in summary, echo is a simple, cheap method to diagnose and quantify AHD, practically all subsets. It prognosticates clinical course, it guides therapy decisions, it detects complications, and it monitors clinical progress. Thank you very much for a patient response.
Thank you, Dr. Jhala, for such an extensive covering of the echocardiography. It is extremely important because many of our colleagues do that in peripheral areas also, and echo becomes an extremely important parameter along with the ECG. Now we come to one of the most important things which most of us as cardiologists are not that familiar, except people who have got taken training. So, and CT scan or CT angiography is coming up in a very big way, not only for diagnosis, but even in an emergency department to as a competition to the ECG, and or as an accompaniment to the ECG and to the enzyme test that we do. And to know what is the exact role of CT scan in diagnosis of IHD, we have one of the most experienced person in this field, Dr. Mona Bhatia from Escorts Heart Institute. She is director and head of the department. She chair International Regional Committee of Society of Cardiovascular CT, vice chair Advocacy Committee, past convener Cardiac Imaging Cardiological Society of India. And we have, at least I have heard her in several conferences. She is one of the best speaker as far as CT angio, whatever talks that I have heard. And it's always looking forward to you, ma'am, to listen to how CT can be useful and what are the advances in CT, how it has improved over a period of time. Dr. Mona Bhatia, please.
Thank you so much, sir. That's a very kind introduction. And I'm happy that you've heard me through multiple places, so that's really nice. It's a it's an absolute pleasure to be here. It's a privilege, and I'm glad I'm speaking on this cardiology forum. And I do hope I will bring some new vistas and new knowledge to you all. And any questions, I'd be happy to take them at the end. So we're going to be talking about calcium score and CT coronary angiography. Now, India faces a real looming epidemic of ischemic heart disease. And we know that ischemic heart disease today is the biggest indication for cardiac CT. What is the role that CT plays in ischemic heart disease? First is the risk stratification of the asymptomatic individual who comes into the OPD. The second is to guide management in the stable symptomatic patient. And the third is to predict outcome. So let's start with the first, which is risk stratification in the asymptomatic individual. Now, coronary calcium, we know, is not an aging phenomena. And that is why it is very important to see if there is any calcium. The first step of a cardiac CT is the calcium score. And using this as the fact, we know that calcium only occurs in the exclusively atherosclerotic arteries. In the continuum of atherosclerosis propagation, we know that coronary calcification is evidence of subclinical disease, and it may progress to overt coronary artery disease. So our intent is either primary prevention or secondary prevention. And whatever it is, we want a very reliable risk stratification tool in order to find when there is calcium. How do we do the calcium scoring on the CT? It's an automated software. It tells us the distribution, the density, the weighting, the size of the coronary calcium. So while the first one has very small spotty calcifications, in the right one, you can see that there is more extensive calcification, which is all colored. So when we're talking about the coronary calcium score, the way the scan is done, it's a very easy scan. It's very rapid, takes hardly 10 seconds. It does not require contrast. There's no IV line, no patient preparation. It's a low radiation dose. It's less than what we use for a mammography. It's a very strong prognostic indicator. It's inexpensive, reproducible, easily interpretable. And while we're doing this scan, we can also look for other non-coronary causes of acute chest pain. Suppose there's something in the lung, we pick it up. Now, coronary calcium as a predictor, we know that irrespective of ethnicity or color, the MESA trial had demonstrated that calcium score is an exceedingly important tool. And compared to other alternatives as a prognostic test, when the calcium score is 0, it has a higher sensitivity than the stress MPS, the stress echo, or the stress ECG. How should we interpret this score? We have two ways, the absolute or the percentile score. The absolute score, if it's 1 to 10, we call it minimal. 11 to 100, we say mild. 101 to 400 is moderate. 400 to 1000 is extensive, and over 1000 is very extensive. So we have these absolute measurements. But more important than the absolute measurements is the percentile score. If the rate of change, that is what is really important. If at 40, the calcium score is that of a 60-year-old, then we have to see that the rate of accumulation is faster. We need to aggressively treat these individuals, even if the absolute score looks good. So we need to slow down the rate of progression. The next is, after this asymptomatic individual, how do we handle stable symptomatic patient, and how does CT help in their management? We know that when we have stable chest pain, the challenge for the cardiologist is that the symptomatology, the clinical workup, the serum markers, and the ECG are not all totally reliable. And our spectrum actually runs all the way from a normal to a severe and critical disease. And while at one end of the spectrum, we need no cath, but at the other end, we might want to have an urgent cath. So what we need is a very fast, reliable, accurate, and non-invasive tool. One, to rule out the coronary artery disease at one end of the spectrum. The second is in the middle and in the right-hand side of the spectrum, we want to aid in the diagnosis. We want to understand the extent and severity, both of anatomical and flow-limiting coronary lesions. Based on this, we want to predict outcome, we want to guide management, and we want to also exclude other non-cardiac causes of chest pain. The armamentarium of tests that we have are, one, the anatomical evaluation of the coronaries, and second is a functional evaluation to understand the impact of that stenosis, whether it's myocardial ischemia or infarction. And what are the chief competitors? For the anatomical evaluation of the coronaries, we know that CAG has held the position of the gold standard. And now what we have is a non-invasive CT angiography, which is trying to vie for that gold standard. On the functional aspect, we know that invasive FFR holds the position of the gold standard. But we have multiple other studies, such as the ETT, the echo, SPECT, PET, CT, MR, with and without stress, and the CT FFR today. So the chosen test must, at one end, reliably rule out disease, and at the other end, tell us when it's critical disease, give us an accurate stenosis assessment, and possibly guide us to taking the patient to the cath. Starting with the rule out of coronary artery disease, the diagnostic performance of coronary CTA is outstanding. Its negative predictive value is very high. And if you have a patient with impeccable coronaries like this, there's extensive literature to support. It has a very high negative predictive value, and it can effectively rule out coronary artery disease. And that is why CTA has had the position of being on the appropriate risk criteria at the low and intermediate pretest probability of coronary artery disease since a long time. Is CT only useful for its negative predictive value? How reliable is it in the diseased coronary? For decades, we've had this preoccupation with coronary stenosis because that's what we could fix. And that is the reason why CAG was in the position of the gold standard. But with advances in CT technology, we now have faster acquisition, wider scan range, a higher spatial temporal resolution. We even have dual energy and spectral capabilities, which allow advanced post-processing. And we have excellent assessment of the coronaries with very few non-accessible segments. Even single clicks, we get manipulation, we get automated central line evaluations, we get coronary tree extractions, we get ribbon views of all the coronary arteries, including their branches, and we can have a very accurate stenosis estimation, both diameter and area-wise. Can CT have an incremental benefit over the gold standard ICA? That is always the question. So when the patient comes, can we actually say that the CT is enough? This is a patient who came and there was a significant LCX stenosis, as is evident here. At the same time, there was a plaque in the right coronary artery. The patient was referred to PCI for the culprit lesion, which was in the LCX. If we look at the CAG, there was a single vessel disease, and this is the pre and the post PCI images of the LCX. For the coronary stenosis, there is no doubt that the CT to ICA has an excellent concordance in the detection of the culprit lesion. So compared to other non-invasive modalities, be it exercise ECG treadmill, echo treadmill, dobutamine echo, exercise nuclear treadmill, or pharmacological nuclear, we know that CT is better than most other non-invasive modalities in the detection and exclusion of obstructive coronary artery disease. But what is the therapeutic consequence of stenosis? Because we know that the confirmed registry had evaluated and said that increased severity and extent of coronary artery disease is associated with reduction in survival. And based on coronary stenosis, high-risk patients benefit from specific therapies. But in the low-risk group, the absolute number of deaths is much higher than in the high-risk group. So imaging stenosis doesn't seem to be enough because majority of the lesions causing MI are not high-grade. Most acute MIs and sudden cardiac deaths are caused by low-grade plaques and not stenosis. So when we're talking about an acute MI, it is the plaque rupture that accounts for 70% of the fatal acute myocardial infarctions. And what constitutes this vulnerable plaque? Well, when we're looking at a vulnerable plaque, we're looking at a low attenuation, lipid-rich intraplaque core. It usually has a positive remodeling, so it's much wider than the original artery. There's spotty calcification within it. It gives a napkin ring sign on the short axis, and there is a serial progression that we see over time. The disadvantage CAG has is, although it is the gold standard for the lumen, but it is only a luminography. So you can see that on the luminography, we could see that there was a very mild narrowing here. But what we couldn't see was this area was filled in by a vulnerable plaque. So CT has the advantage that it shows us the stenosis and the cause of stenosis. It shows us that lipid-rich plaque with positive remodeling, spotty calcification in the RCA. And definitely, things are moving towards plaque assessment earlier than just stenosis. The presence of any atherosclerotic plaque prognosticates adverse outcome. And even a mild plaque can have a 6 times higher mortality for patients with triple vessel disease. So there is an incremental risk prediction beyond stenosis when we're talking about plaque assessment and characterization with these features of spotty calcification, low attenuation plaque, positive remodeling, and percentage aggregate plaque volume. The assessment of risk prediction based on clinical features, severe stenosis and atherosclerotic plaque was assessed, and it was found that the plaque predicts better than clinical features and stenosis. And that is the reason why when we are dealing with management of ischemic heart disease, we are looking at hybrid imaging where the functional evaluation is equally important as is the anatomical, because we want to see what is the impact of the stenosis for ischemia, infarction, and LV function. And that is evident from the ischemia-guided revascularization, which improves event-free survival. So ischemia judgment is extremely important. And this was evident from the FAME trial where angiographic stenosis does not necessarily indicate hemodynamic severity. In fact, invasive FFR today is the gold standard for lesion-specific ischemia. Now the question comes, can CT identify ischemia and create the desired hybrid of anatomy and physiology? CT does allow evaluation of myocardial perfusion, both static and dynamic, and so you can get the time attenuation curves of the myocardial blood flow and see the detection of the perfusion defect. So you can see the black area in a perfused myocardium and know when there is a perfusion defect. Dual energy and spectral imaging further helps to get a better identification of the perfusion defect, and now with superior CTs, we also have reduced artifacts. Here you can see that there is a complete reversibility of the ischemia between stress and rest on the CT perfusion. This was in the LED territory in the septum on the short axis view. Here you have a partially reversible myocardial ischemia, whereas in this case, you can see that there's a matched perfusion defect with a scar formation in an RCA occlusion. So the interpretation of perfusion is very similar to other modalities like nuclear medicine, where you would be looking at a reversible defect, a fixed defect, or a partially reversible defect on stress, rest, and delayed enhancement in order to evaluate whether you're talking about stress-induced ischemia, myocardial infarction, or a peri-infarct ischemia. Microvascular disease is another feature that can be assessed on CT. You can see a very circumferential subendocardial perfusion defect, and the ICA may not show any significant disease. This may be seen in patients of diabetes and hypertension. Combining the CT and the CTP is particularly useful because you have incremental benefit with the sensitivity and the negative predictive value rising to almost 100%. Recent advances in CT are the CT-FFR. This is a computational fluid dynamic which allows calculation of the non-invasive 3D FFR of the entire coronary bed. And this is from a typically acquired CCTA. You do not need to do any extra imaging. There is no modification in the protocol, medication, and it is not influenced by changes in BP or heart rate or contractility. The NXT trial demonstrated that the diagnostic performance of CT derived non-invasive FFR in suspected coronary artery disease definitely upped the game when we were talking to comparing just the area under the curve for CT versus area under the curve for FFR CT. The area under the curve on a per patient and a per vessel basis increased tremendously. So in the diagnostic performance of CT FFR, when it was compared to various other modalities also, it was found to be superior for lesion-specific ischemia. And here they've compared it to stress echo, CCTA, SPECT, invasive in angio, IVUS, CCTA tag, and CMR. Going on to prediction of outcome, now we know that the treatment based on drug therapy versus the mainstay being interventional therapy or bypass surgery. And in the prediction of treatment, we want to look at primary outcome, what will be the technical success of intervention, and the second in the long-term outcome. When we talk about the technical success of intervention, chronic total occlusion is one place where CT is really useful because the success of intervention is lower if you have a longer lesion length, if you have more tortuosity, calcification, and the lack of visibility of the distal vessel. Whereas the success rate of intervention is higher if you have a short lesion, non-tortuous, non-calcified with a visible distal vessel. In the long-term outcome, what we're looking at is regional and global LV function. So here you can see the automated contour tracking, LV function, wall motion, wall thickness, perfusion defect, and delayed enhancement, all of which can be done in order to check what will be the long-term outcome. Because if you have an infarct with wall thinning, then it's unlikely that it's really going to recover whatever the intervention. So CT also has other roles in post-MI cases, such as finding this wall thinning with fatty replacement. And here you can see the LED territory. Then you can have a thrombus at the apex, which can be very well demonstrated. You can also evaluate stents and grafts. And here you can see how you can actually look at the stent patency for presence of contrast within the stent. This is a patient where there was a in-stent restenosis. Occasionally, you may have patients who come with post-PTCA with a persistent abscess around the stent, or you might even have a situation where post-CABG, there may be graft stenosis. So CT today is the gatekeeper to the cath lab. If you have a level of risk which is very low, you can assure the patient. If it's high, you might want to take the patient to cath. If it's low, you might want to prevent and actively. But if it's borderline, you can't tell, or it's medium, you may want to take to another level of stress and ischemia imaging in order to have a substantial proof. So CT today is a potential one-stop shop imaging for ischemic heart disease, where we can evaluate the coronaries, we can look at function and perfusion. Now, not only does CT stop at just the coronaries, but sometimes we also have situations where patients come with acute chest pain. And then we have the triple rule out where we're looking at either PE or dissection. And here you can see the aorta where there is a extensive dissection which is seen. CT also helps in looking at other features here. This is a very large MAC that is seen in the mitral valve area. This is a very large osteosarcoma with metastases in the intracardiac chambers. You might have a situation where the pericardium, and then again, the chronic calcific pericarditis seen in tubercular patients in our country is very well evaluated. And here you have a pericardial effusion in another patient. So definitely CT helps to give you a more global picture and evaluate not only the coronaries, but also the cardiac chambers and the pericardium. So specifically for ischemic heart disease, CT should be the first line test in the non-emergent stable chest pain patient, one to rule out coronary artery disease, then to assess the stenosis severity and extent, then to characterize the adverse plaque features and assess plaque burden, because this can improve risk prediction. You can assess the impact on myocardial perfusion, and the FFR CT today is the prognostic test with therapeutic implications. Thank you so much for your patient listening.
Yeah. Excellent talk. Thank you so much. And you have covered almost everything in CT that we need to know as cardiologists. And I think now we can have some discussion and some of the questions which have come. I will be first taking up questions for Dr. Mona Bhatia because I was told that she has to leave, if possible, early. Is that correct, ma'am?
Yes, I have another conference that is going on.
Okay, I know you're the busiest city person. I know that. Yeah, but I have some questions for you. There are no questions.
But I'm going to say something. I'm very impressed with the cardiologists. You are the biggest improvisers and innovators, I must say. And it's very interesting how yesterday I was in a TAVR day, a mitral day, and today again I'm in a post-TAVR complication day. So I'm just thinking how cardiology has changed so much.
Yeah. So that is the first question I have for you. Because I have some questions which I think are interesting. Now, do you think this CT, what we do for cardiologists, don't mind for saying this, so should the cardiologists also be learning this, or should this be a radiologist domain? Just a superficial thing. And for radiologists also, if anybody wants to do, is it a specialized thing you all do, or you also do all other types of CTs? Or is it that simple? I just want to know all this. Yeah.
Okay.
That's first
so
question.
I'm a radiologist by training, so I do all CTs. So I do chest, abdo, brain, everything. But let me tell you one thing. I think I'm a good cardiac radiologist because I work with heart teams. I don't work singly. I work with the cardiologist, and that's the only way we can do it. So whether it's the cardiologist who gives his input or the radiologist who gives in his input, no cardiac imaging can be perfect unless both parties are in it. And that is for certain. So, you can turn around and say, this is what we're seeing, but, somebody has to say whether they're going to be able to dilate that. What's the best way? You might have a complicated case where, not only that, things like even people with post-MI aneurysms. And if you want to do a resection of the aneurysm and then, suture it up. So you want to have the whole volume of the aneurysm post-MI, and you want to know what will be the ejection fraction at the end. So there's so many things to it that needs to have a heart team. It has to have both, whether it's the cardiologist and the radiologist, or whoever is the cardiac imager. It could be the cardiologist in some places. So I don't think it depends on what is our initial training. I think if we have to be cardiac imagers, we need to have both sides of the coin together.
Okay, so what the question was that should you be concentrating only on cardiac CTs and cardiac work, or you can do all types of? That's what was my question. Huh? So you think you can do everything and cardiac also? Is that correct? I just want to know, because this looks like a very, very highly specialized field to us, but we don't know. It might be a very simple thing for you all because you're all used to it. So that is why
there is no doubt that I personally, 90% of my work is cardiac.
Okay. Ma'am, now there are two more simple questions I have for you, because this is my learning. I'm trying to learn from you. One is, what CT scanner should I send a CT scan to? Like in my place, I don't have you. So 126 is good or 256 is good, or should I confirm whether the CT scan is of what type before I send a person for CT? That's one question. Second thing is, you always do first calcium scoring. At what level of calcium score you will say, I am not going to do this CT angio, you take him up because there's too much calcium. Is there something like that, or you always do a CT angio? These are two questions I have for you.
Okay, so we'll take the second one first, the calcium score.
Yes.
As far as the calcium score is concerned, if it's a calcium score in a patient under 40, and the patient is having symptoms, even if the score is 0, I would do a CT angio followed by it. Why? Because we have a lot of young individuals in our country who come back with with significant disease or have soft plaques which will not be seen on calcium. So just remember, a calcium score of 0 in a younger individual doesn't mean he doesn't have coronary artery disease. If there are symptoms or the ECG changes or TMT or whatever, please take it to the next level. The second thing is, if the calcium score is positive, then I know a lot of places stop at 400, some stop at 800. I don't take it like that, because you see, a lot of our patients are on statins and long-term statins. Statins have been stabilizing the plaques and causing calcification. So we have people in our country who would be in the range of 800, 1400, 2000 calcium. So when you have calcium like that, it's usually along the wall of the artery. So I think we should not stop just because a calcium score came, because you remember, a calcium score scan is done at a spatial resolution of 3 millimeters, whereas a coronary CTA is done at 0.6 millimeters. So when the same calcium score scan is done at 0.6 millimeters or reconstructed at a thinner section, you will be able to see the coronaries much better. So I don't stop just because there's a huge chunk of, I will only stop, suppose I see a very large chunk of calcium in the proximal LAD, which is, I'm going to be certain that this is going to be a significant disease, because there is too big a chunk, and it's not, firstly, I will not be able to evaluate it too much. I will not be able to see the lumen. And the second thing is, this patient is most likely going to need an angiography. So it is not fair to charge the patient for a CTA and then charge the patient for an angio again, in which case I might send the patient directly to angio. But in all probability, if someone says that LAD, we know the LAD territory is gone, our problem at this point is from the ECG changes, we're seeing it's the RC territory, I might still do it even at a very high calcium score. So calcium score is not really a deterrent as far as I'm concerned. I will firstly take it to the thinner sections and see whether I can see enough of the coronaries and whether I will get an interpretable study. Most likely I will. And otherwise, there'll be a lot of patients who you will refuse.
And the last
question,
question,
the second question you had was the level of scanner that you should send it to.
Yeah. That is very important. I thought
okay.
so for us.
So the important thing is that, see, 64 slice up can do a coronary scan. What is important is that the technique must be done very carefully. So if you have a 64 slice scanner, you must make sure that the patient's heart rate is in the tune of 70 to 80 max, preferably 60. Okay. If you have a post-CABG patient where they're anyway on beta blocks and things like that, they'll have good heart rate control. So if you have a good heart rate control, even a 64 slice scanner can give you a very good study. 128 is fine. And of course, the higher you go, the more, what happens when the higher you go is not that it makes a tremendous difference to the study. What it does is that you don't need heart rate control. The other thing is, a lot of the arrhythmias and all, you don't need if you have a single beat imaging, then if there's arrhythmias, all that gets sorted. So if you have a patient with an irregular heartbeat or a high heart rate, that's then complicated, and then that needs to go to a better scanner.
Okay, I have one more question for you. Many times when I refer patients for total occlusion, which are highly calcific and all, some of my CT scan people have refused. They're saying it's so much of calcium, I don't want to do it. In fact, we want the CT scan to know.
But that's the purpose of the CT scan.
Yeah. So that has to be done. Yeah.
I think that is where there is a disconnect in the understanding between the cardiologist and the radiologist.
No, even the radiologist refused. That is why I'm
that's what I'm saying. The radiologist doesn't understand why the cardiologist wants it. That is exactly why I feel the some of my colleagues, unfortunately, don't understand that the whole purpose is we're not looking at the CTO segment. What we're looking at is the landing zone. So lots of people are now coming back with even post CABG, and now they're coming back for they're looking at how can they open something or whatever. There's lots of complicated cases that are now coming back and redos. And those are definitely what you want to know is, yes, there is a patient with a CTO, a long segment. This artery has now closed. Maybe can we open the old LCX that was never opened? Absolutely. So, there's always those CTOs where the whole aim is to map the artery, to map the distal vessel, check whether there is any collateralization, and if there is a landing zone for, a new graft. So definitely that is, I think, the disconnect between the two, unfortunately, the radiologists and the cardiologists in our country.
It's nice to know that we all improve, as time passes. Dr. Jhala or Dr. Gupta, do you have any questions for Dr. Mona Bhatia?
Dr. Mona, I've got again two simple questions. How good is the CT coronary angiography for post PCI and CABG? Is that got most the same predictive value without PCI or CABG, or the predictive value is slightly less?
See, post CABG, it's excellent. There is no two ways, because I don't think any surgeon wants to go back to do an angio. And in any case, you want to see the origin, you want to see the course of the whole the graft, and you want to see the distal zone, and you want to see how the vessels are doing distal to the anastomosis. So for CABG, it's perfect. It's an excellent tool, because sometimes in our country you have jump grafts, Y grafts, this, that. So it's actually excellent. As far as the post PCI is concerned, the post PCI depends on the stent that was originally put. For most cases, artery that is 3 millimeters in size is very easily accessible on the CT. But it should not be, some of the older stents who had very thick struts. So sometimes they can be a little difficult, but usually we have a good chance if it's 3 millimeters and above. And now with the BVS stents and places where there is thinner struts, I think there's no problem. So both situations, I would believe that CT would be your first choice rather than going back to the cath lab.
And the very simple question, a lot of people with a very high calcium score on CT, and they need calcium. So the patient, even the physicians are a bit concerned about giving calcium to such patient. Whether any concern about this?
I don't think coronary calcium has any link to body calcium. And as far as I'm concerned, I don't think that's a link. What I do find in the calcium in the coronaries is the people who've been on long-term statins, because it has stabilized the plaque and then led to calcification. But I mean, I'm sure we could check that with the how the blood levels of calcium impact the coronary levels.
Dr. Jhala, do you have anything to discuss?
What is the take on FFR and CFR?
See, FFR is, of course, invasive FFR is in its own place, and we cannot.
No, I'm talking about CT.
Yeah.
CT FFR.
So that's what I'm saying. So now we're coming to CT FFR. As far as CT FFR is concerned, it's still a little cost prohibitive, because it's still going to to San Francisco to Heartflow, and people are sending the CT scans there, and then you get the result after a day or sometime, whatever. And it's costs about $1,000. So for most of it, the FDA approved one is only Heartflow. If we talk about some other places where CT FFR is available, which is a tool, which is a research tool, yes, it's useful, and it's a great second tool, because it definitely increases, like I showed you, the area under the curve. For from CT to CT FFR, you definitely improve. You also have capability of CT myocardial perfusion. As far as CFR is concerned, I think nuclear medicine has had CFR for a long time, so they still PET and all will still have a little bit of an edge.
Yeah, I think, we would appreciate if you could wait along, but you're free to leave because you have some other commitments.
Thank you so much.
And I think you have answered most of the questions. Thank you so much for being with us.
Thank you very much.
Thank you. Yeah. Now let's come to some of our routine discussion about ECG and echo. Dr. Gupta, there are questions in this. I will just want to read this. In this current COVID, Dr. Vijay Singh wants to ask that in this current COVID era, which is the best modality of investigation to rule out STEMI mimics? Let Dr. Jhala maybe can answer this. In the COVID era, what is the best modality of investigation to rule out STEMI mimics? I don't know what exactly it means to us, but can you think of something which you want to?
Probably refers to differentiating chest pain syndromes.
Syndromes, yes. But yeah. I think the diagnosis will remain the same. Is it correct?
Yeah, I mean, see, basically, I think the safest modality would be, of course, to take an enzyme study and look at biomarkers, because that does not involve any close interaction with the patient. That way, only a technician goes and collects the blood, and maybe you get. But then, second choice, I think, of course, after an ECG, the second choice would be an echocardiogram. Like I said, if there is a typical chest pain and echo is completely normal, and if you're looking at the person while in chest pain, which has been going on for about half an hour to 45 minutes, if your echo is normal, you can safely treat it as non-cardiac.
Yeah. On the same lines, I had a question for you, Dr. Jhala. What I thought was that if somebody comes with a chest pain, and you have sent his enzymes, and he has a baseline left bundle branch block. That is one place where I thought echo would be helpful. And another situation where I want your comments on this. People have circumflex acute occlusions and they come with an acute MI, but the ECG remains very non-specific and they get neglected that they don't have an MI. So echo in an emergency setting, in which are the scenarios where you would really have the real benefit other than ECG and enzymes, I would say. Can you comment on that?
Yeah, so circumflex is the silent zone of ECG. And these can be very nasty because you can have acute mitral regurgitation and papillary muscle dysfunctions. And these people can be quite seriously ill. So this is where echo definitely does not have a blind spot for circumflex. In multiple views, we can view the circumflex territory easily. And if it's a large enough infarct, you'll definitely be able to identify it. That's one. Secondly, if you have pericarditis, either with or without MI, or just plain simple pericarditis, it can be quite difficult to diagnose. And the ECG changes sometimes can be quite disturbing. The ST elevations may be mistaken for ischemic ST elevations. So this is where echo will be extremely useful. Multiple leads showing ST elevations with no wall motion abnormalities, patient in chest pain. Certainly pericarditis, unlikely to be an ischemic episode. Dissecting aneurysms, maybe you may not be able to diagnose the dissecting aneurysm, but many of these dissecting aneurysms cause pericarditis and pericardial hemorrhage. So that is where echo is very important, where you have a patient with a diagnosed aortic dissection. And if you have pericardial effusion, that's emergency surgery. So I think these are some of the areas where echo is extremely useful.
Yeah, where the other things may not help you much. That's the advantage of the echo. Yeah.
Ventricular septal rupture, acute mitral regurgitation, aortic regurgitation, ruptured sinus of Valsalva.
Absolutely.
All these are easily diagnosed on echo.
Very, very vital. Dr. Gupta, there was one question which I thought of asking you for the favor of everybody. When would you not do a stress test? Means you will say that I don't want to do a stress test on this person because of this. I will send him for either angiography or other investigation. Is there any situation where such a thing can happen?
I think in the current scenario, patient has got a very typical angina, male patient, where I suspect that the patient is having a severe coronary artery disease. I would like to send him directly for an angiography. That's where I'm suspecting that patient has got severe coronary artery disease.
Yeah, very good. Jhala, would you like to add anything to this? Means like the normal contraindications for a stress test, what we think of. One is typical chest pain. You will definitely not want to put him to exercise. Yeah.
See, I think most of the left bundle branch blocks should not be undergoing exercise test because there are various situations, like if you want to just do the effort tolerance, etc. But by and large, I think, and paced patients. Patients on right ventricular pacing, they should not undergo a stress test.
It will not help you. Yeah,
it won't help, and it will create a lot of confusion in the patient. I mean, though we as clinicians understand the implications.
But the only other thing that comes to my mind is auscultation of the patient, aortic stenosis. If there is a severe aortic stenosis, one has to. Pardon? Absolutely. Yes, Dr. Gupta. Pardon?
There are a lot of absolute contraindications are there.
Yeah.
Those are the typical like severe aortic stenosis, patient congestive heart failure, patient having severe arrhythmias, all those, or patient having some very high blood pressure, more than 180, 110. These are the some absolute contraindications for doing stress test.
Yeah.
Post MI within 3 days.
So there's one question from Dr. Arun Kamble, myocarditis and 2D echo. Do you want to comment on that, Dr. Jhala?
Yeah. Unfortunately, echo does not give you tissue diagnosis. It will give you LV dysfunction. And currently, I think the only way to distinguish myocarditis, pure myocarditis, would be on MRI and not on echocardiography. You can have some, if you have myopericarditis, you can see it well. But other than that, or if you have a pericardial disease like a pericarditis, which is also going into the myocardium, then it might help you. It can give you complications related to myocarditis like valvular regurgitation and LV function, but I don't think it can give you exact diagnosis of myocarditis that way.
I want to take on from this question. because recently there were reports of young sportsman, football player, who recovered from COVID and then had a sudden death on the field. And one of the reason given was smoldering myocarditis, which was missed out because he never went an echo. He was normal, asymptomatic. So I think, especially people recovering from COVID and all, probably an echocardiography in the follow-up period would be very useful. What do you say? It had nothing to do with the IHD per se, but otherwise, what do you say?
Because LV function is one of the most important determinants of sudden cardiac death.
Yes.
So if you have, even early LV dysfunction as detected by strain echo. So I think in this situation, probably not allowing vigorous exercise would be the, especially if you say it's post-COVID or something.
Yeah, even young or old, it makes no difference when you started doing exercise. Even if you are an athlete before, and if you have gone through COVID, it may not be that you should do a stress test or you should do an exercise unless you have gone through some sort of a examination. What do you say, Dr. Gupta? You have to say anything on this?
Patient who has suffered from moderate to severe COVID infection should undergo a cardiac evaluation, because I think there have been a lot of reports regarding cardiac involvement in moderately or severely affected COVID-19 patient. So doing a simple test like 2D echocardiography and evaluating them from cardiac point of view is important.
Yeah. So I think we have come to the end of the examination. Our time also is up, perfectly 12:35 as ordered by Dr. Ketan. So I would hand it over back to you. I suppose we have had a good discussion. I'm thanking all the speakers and for the good discussion and the good talks. And let me hand it over to Dr. Ketan for Dr. Dwivedi to do the good quiz. Looking forward to it, sir. Thank you very much, Ketan. Yeah.
Thank you, Kane sir, for wonderfully conducting the panel discussion and moderating the entire sessions with three excellent speakers, Dr. S.B. Gupta, Dr. Darshan Jala, and of course, Dr. Muna Bhatia. Friends, let me remind you once again, as this is an accredited program, I would request all of you, I'm sure you must have done it, fill in all your details which is required when you must have entered at for this webinar. The details which are required for accreditation program, all your name, mobile number, your email ID, your registration number, along with which state council you are registered. So all these will be required. So please do fill in. And now we will come to the most awaited session, and that is none other than ECG quiz session, and which we are going to have. And this is again, it is going to be on diagnosis of IHD, and for which we have a quiz master who is none other than reputed Professor Dr. S.K. Dwivedi from Lucknow. Sir is a professor in cardiology at King George Medical University, Lucknow. He has been a fellow of various organizations, fellow of American College of Cardiology, fellow of European Society of Cardiology, and so on. He has been a past president of Indian Society of Electrocardiology. He has been a past president of CSI UP chapter. His special interest is in electrocardiology and clinical cardiology. Sir has conducted many workshops on ECG. He has done a fantastic conference, ICCON, I remember, done at Lucknow. Sir is an excellent teacher and an excellent human being. Now, I would give certain basic things for you to go for it. As this is going to be an interactive session, I want all of you to participate into it. You may be right, you may be wrong in the answers. Don't worry, your identity will not be revealed. It will come as a KBC graph. You will know how many % have voted for which option, but I want you to vote for it. Secondly, when you are voting for it, obviously you will see, you will have to minimize your screen, rather than going into the full screen, which you will be otherwise seeing it, you will have to reduce your screen size. So on the right hand side, you will able to see the questions. That is if you are using on a laptop, and if you are using from a mobile, you will see the questions at the bottom. So please do vote for it. I'm sure this will be a good learning session. So with this remarks, it's over to you, sir, Dr. Dwivedi, sir. Thank you so much.
Thank you, Dr. Mehta. Yes. Are you able to see my presentation now?
Yes, sir.
Okay. Thanks for kind words. And this has been remarkable earlier sessions. Learned a lot from Dr. Jala, Dr. Gupta, and Dr. Bhatia. So let us come to the ECGs of acute coronary syndrome and see where actually the block is. So I've seen that there are 4 ECG quizzes in coming 4 Sundays. So I have modified it to come to the isolate localization of the block. So this will be a ST elevation thing. But before going to that, yes, here comes the first question. Before going to the question, I would say that one must remember few things. First is that if you are analyzing a ECG of ST elevation MI, then the analysis or the localization of infarct related artery is best if it is first infarct. And it is the earlier ECG rather than later ECG. So prior MI, it is not so specific. Infarct is, let's say, second or third infarct, it is not specific. These are the patients who are real patients. And in all these patients, the angiogram had been done. They were the first infarct. So here comes the first question. This is a 56-year-old male presented with chest pain for the first time for last 4 hours. And these are your options. A, LAD proximal, B, LAD distal, C, LAD plus RCA, fourth, proximal RCA, fifth is none. That may be an option in some of the answers. So your time starts now.
You will get total 30 seconds to answer.
So what I get the answer is LAD proximal is 1/3, 1/3, 1/3. LAD proximal, LAD plus RCA and proximal RCA. This is changed now. This is 38%, 25, 25, and then least is LAD distal, that is 12.5%. Okay. Now let us come to analyze this. So let us go first. When we are analyzing what we are, why is there confusion is because there are multiple elevations in lead 2, lead 3, AVF, V2, V3, V5, V6 also. But once we are analyzing the LAD, then LAD occlusion is diagnosed by the presence of ST elevation in chest leads, V2, V3. So I'll go here. Chest lead elevations, if V2 and V3 both are elevated, then it is LAD. So first thing is to rule out whether LAD is involved or not. If 2 and 3 both are involved, there is LAD. Once you have diagnosed LAD, then you have to go to the site of lesion in LAD by seeing the limb leads and augmented leads. Why limb leads and augmented leads? ST elevation in limb leads will point towards the injury, and ST depression will point away from the injury. That is what is called as the reciprocal change. Let us have the example. Let us believe that this is left anterior descending artery. This is septal 1. This is diagonal 1. And there is a distal block. So what will happen? Naturally, the force or the current of injury will come anteriorly because the myocardium is situated anteriorly, the V2 and V3. But along with that, the forces will be, most of the injuries will be towards the apex. So it will be going away from the avial. If you see here, it will be going away and it will be directed inferiorly, the vector. That means lead 2, inferior leads, that will lead 2, 3, an augmented lead AVF will be elevated. So in a distal LAD block, the inferior leads will be elevated. And if at all, since the vector is going away from the diagonal, the AVL may be depressed. Now we go here. You have diagnosed LAD by ST elevation in V2 and V3. Now, after that, you go to site of localization in the artery. What you see here is ST elevation in inferior leads. That means the current of injury is going inferiorly towards the apical area, more towards the apical area, and it is away from the AVL. That means this is a distal LAD. The confusion is because we have been taught that multiple elevations, larger infarcts. No, it may not be true necessarily. We'll come to see also in the further ECGs. So here 8 leads at elevations, but the infarct is actually smaller. Now come to the other example. Let us say the block in LAD is earlier than septal one and diagonal one. So what will happen? Now the lateral area will also be involved. So what will happen? The AVL will start elevating and the vector or the current of injury will shift from inferior towards the left side. Towards the left side. So left leads will be elevated and AVF may be depressed. That is what here. So what you have done here, 2, 3 are elevated. A lead V2 and V3 are elevated. So you have diagnosed the LAD disease. But what you see here is that AVL is elevated and 2, 3 AVF are depressed. So see here, only 3 leads or 4 leads are elevated, but this is a proximal elevation. So in LAD disease, if there are many elevations, including inferior, it is a smaller infarct. If it is a lesser number of elevations and more are depressions, then it is a larger infarct. I hope this clarifies. Now let us go to the case number 2. This is a 56-year-old man. The history probably doesn't matter. It may remain the same and you may find the history same in all ECG. It has to be first infarct. So what you are seeing is this ECG. You have to see all the leads. You have to see and then try to find out what is the site of infarction. Again, the answers are LAD proximal, RCA proximal, left circumflex, or RCA distal, and none is also an option. And your time starts now. The reading of ECG in ST elevation MI should carefully look all the leads. Okay, and let us see what is the result here. So here, LAD proximal, LAD, no, this is the second one. LAD proximal and RCA, D is RCA distal. Okay, let us go back to the ECGs. LAD proximal and RCA distal. Now this patient has come in with a chest pain. 4 hours, it is anginal pain. So we have to look carefully for ST segment elevations. And if you see the ST segment elevations, if at all are there 3 and AVF, right? Plus there are small Q waves. But at the same time, if you analyze all the leads, there is no ST segment depression in AVL, which occurs with RCA. We'll come to that later. And the R is more than S in V1 and V2. Then if you further analyze, there is minor ST segment coving in V5, V6. That means there is something going on in the inferior and lateral area. And RS V1, RS ratio in V1 is more than 1. Might be indicator of a posterolateral area. Now, in any ECG, whenever you are doing ECG, one should take, if the ECG is not clearly diagnostic, there should be at least 15 lead and right-sided leads. So once you added V7, V8, V9 and right-sided leads, look, you started seeing ST segment elevations in V7, V8, V9. However, V3R, V4R do not show any ST segment elevation. So this patient has the inferior posterior lateral infarction because posterior because R more than S, inferior because 2-3 AVF, and then posterior is very clear here. So one can say that posterior infarction is diagnosed. Now, isolated posterior infarctions are uncommon. Most of the times, more than 90% times, they are associated with inferior infarctions. However, there may be subtle changes of small Q waves that may be missed unless we go for posterior leads, that is V7, V8, V9. So the message here with this is that whenever you see something abnormal, particularly R more than S in V1, V2 or equal, then go for 15 leads if the chest pain is classical. So this patient is a left circumflex, and we know that half of the patients with left circumflex, because it's supplying the posterolateral area, may be missed on ECG. That must always be in the mind once we are analyzing acute coronary syndrome. See here, what is happening here, what you are seeing here is marked ST segment depression. Now, this is another kind of circumflex presentation. But at the same time, if you see, there is ST segment elevation in V6. And remember, you have to try to localize the infarct by the ST segment elevation. So here 2-3 AVF is elevated, but along with this, there is V6 elevation also. And there are reciprocal changes. So this infarction can be this has to be RCA or LCX because inferior leads are involved. Now, once there are V1, V2, V3 depressions, this confuses the issue, whether it is LCX or not. However, how to sort this out? The sorting out may be somewhat simpler if we go to the depressions in V3 versus elevations in lead 3, right? ST segment depression in V3 and compare it with ST segment elevation in lead 3. If this comes to be more than 1, then it is a circumflex infarction. So a broad, or let's say a thumb rule may be, if the precort there is ST segment elevation in inferior leads, that is 2-3 AVF, diagnosis of inferior wall, can be LCX or can be RCA. If there is marked ST segment depression in V1, V2, V3, it is likely to be a circumflex, particularly when V3 depression is more than the elevation of lead 3 and V6, V7 are also elevated, right? So this is the another extreme. One of circumflex infarction is tall R in V1 along with posterior lateral ECG changes. Second is depression in precordial leads along with posterior lateral changes. Now we come to third case. This is a 56-year-old male presenting with chest pain for the first time. Same history will remain same. What it is: LAD proximal, LAD distal, RCA proximal, or circumflex. And your time starts now. So let us see what the answer is here. Oh, 50-50. RCA proximal and LCX. There is some change. There are some who believe it is LAD proximal, RCA proximal, and L6. So inferior MI still changing. Majority believe it is RCA proximal. Okay. Now let us analyze this. What is peculiar in this ECG? This ECG is showing ST segment elevations in V1, V2, V3, along with ST segment elevation in Q3 AVF as well. However, there are certain other things also. People have seen inverted P waves in 2,3 AVF. That may indicate that artery which is supplying the atrium may be involved. LED doesn't supply atria. Atrial supply 50 times comes from RCA or circumference. So it is unlikely to be LED. However, V1, V2, V3 is elevated. Then how to proceed? Before proceeding further, I would also show you the ECG of this patient, right-sided leads and inferior leads. And what you are seeing here is right-sided V3R, V4R, ST segment is elevated with T upright. That means there is a right-sided infarction as well. And then added to it, V7, V8 is also showing elevation. That means posterolateral area is also involved. So what it shows is right-sided involvement, inferior left ventricular involvement, and posterolateral side of the left ventricle. That can only happen once there is a proximal RCA occlusion. Why proximal? Because the P wave is inverted here. Can you see now? The P wave inverted, and atrial branch, if it arises from the right coronary, is the first or second branch. So it has to be a proximal RCA. You are also seeing some conduction delay there. That can occur only when the AV node is involved. And we know that right coronary supplies AV node more than 90 to 95%. So right coronary, or whatever is the dominant, but it is supplied from the right coronary artery 90 to 95% times. So right coronary, indicators of right ventricular infarction, that means it is the proximal RCA. So why it is not anterior wall infarction? Because Q, there is deep Q in V1, V2 with ST segment elevation. So one has to see, when you find V1, V2, V3 elevation, one has to see whether elevation in V1 is more than V2 or not. If elevation in V1 is more than V2, then it may be an effect of V3, V4R elevation. I hope I am able to explain. If it is LED, V2 will be more than V1. So remember I said LED is diagnosed by V2, V3 elevations. Why not V1? Because V1 can be because of RCA and because of an indicator of right ventricular infarction. So if V1 is more than V2, V3, then it is right ventricular infarction. If V2 is more than V1, then it is LED disease. It is, see here. So this becomes RCA proximal. See here, 2,3 AVF elevated, and see V1, V2 elevations. Both are elevated, but don't diagnose as an anterior wall infarct. V1 is more than V2. So the message from this is that when you are analyzing elevations in precordial V1, V2, V3 and inferior leads, it can be LAD or RCA both. Then look at V1 and V2. If V1 is more than V2, this is inferior infarction RCA. If V2 is more than V1, it is anterior infarction distal LAD. Coming to this case, again the history remains same. 56 years old man presented with chest pain first time. Remember, angiogram has been done in all these patients. So the options are 4, LED, RCA, LCX, and left main. And the time starts now.
Sir, we will give them proper 30 seconds. After the buzzer rings, then only we will give the interpretation so that it will not change the interpretation.
You give the buzzer when 30 seconds are over.
Yeah.
And you also give me the buzzer when everything is over. I will stop there.
Okay.
That I take it as buzzer.
Yes.
Oh. So let us go to answer 4. So half believe that is LED. None believes that is LCX. Right. Let us go to the presentation. So now something is, now this is different ECG. Why different? Because this is a LBD. QRS is wide, left membrane morphology. So the diagnosis of a acute myocardial infarction is very difficult. And that is where Garbosa criteria comes in. Garbosa criteria say that if there is a concordant ST elevation in positive leads are V4, V5, V6, whichever are the positive leads in chest, or the limb leads also. Whichever are the positive leads, classically V4, V5, 6 are positive leads. If there is a concordant or same-sided ST elevation, this gets 5 points. If there is concordant ST segment depressions, that is what is seen here. V1, V2, V3, V4 are downward lead, and there is a concordant ST segment depression, that gets 3 points. And if there is a ST elevation of more than 5 millimeters, why? Because some amount of ST elevation, discordant ST elevation, is normal in the left bundle block. That is why it gets 2 points. Now, this is a very sensitive marker, and this is a very specific marker. Sensitivity is low. That means it need not be present in all infarctions. That is why it is said that diagnosis of infarction in presence of LBB is difficult. But once these signs are there, ECG signs are there, then the specificity will be higher. And see here, the specificity is between 85 to 95, 98% times. Now, if you see here, so now remember one more thing. There are other criteria of diagnosing infarction. Let us say upstroke notch in 3AV, in upstroke notching on S wave, or notched ST, or say Q waves in V5, V6. They are also the criteria. But ST segment criteria, they tells the site of arterial occlusion. And notches or Q waves in V5, V6, they tell a scar. So if you see here, there is depression in 2, 3, in V2, V3, that tells us that the artery is likely to be proximal LED. Left circumflex rarely, if at all, gives rise to LBB. RCA can give rise to LBB. However, the mechanism is not really because of the infarction or the damage. And thirdly, there was earlier teaching that new onset LBB, when you suspect you thrombolize, it is no more there. That has been removed from the thrombolysis criteria because of the controversy that it is not true. Half of the times, there is no coronary artery disease. Half of the times, the LBB which presents is a pre-existing LBB. That is why that criteria has been removed. It was well ingrained and remained for nearly 3 decades before being removed. So this patient presenting with concordant ST segment depressions is a patient of LED disease. Now see here, again a LBB. See, there is concordant ST segment elevations in 2, 3 AVF, and this came out to be right coronary artery, inferior limb. See this. ST elevations discordant more than 5 millimeters in V3, plus concordant ST elevation in V5, V6, acute MI. This was again a left ventricular sunlight. Now coming to fifth case. This is a 56-year-old man. Again, history is not relevant. This is the ECG. I apologize. I do not know whether the ECG is being projected well or not. So these are the options: LED proximal, LED distal, RCA proximal, and left main. The time starts now. Okay, let us see the answers. So majority, more than nearly half, have said that this is LED. Some people believe it is RCA, and some say that it is left main.
Sir, you'll have to go down. I think you're seeing the previous case. Yeah.
Yes. I'm sorry. So LED proximal 1/4 and 37% RCA proximal and left main, and LED distal nobody picked up. This ECG is important. One should not miss this ECG. Let us see how should we proceed. So this patient is presenting with chest pain for the first time, prolonged chest pain. A high likelihood of ST elevation or non-ST elevation, in fact, should be kept. That is number one. So you start looking for ST segment elevations. And if you see, there are ST segment elevation, there are widespread ST segment depressions. See, all leads, lead 1, lead 2, lead 3, AVL, V2, V3, V4, V5, all are depressed. Only 2 leads are elevated, AVR and V1. And in that also, AVR is more elevated. ST segment elevation in AVR is more than V1. Now, whenever you are analyzing a ECG, one has to spend time and in isolation should look for AVR as well, irrespective of what is the site of lesion. Whatever is the artery involved, AVR must be looked for. So what you saw here is that AVR is elevated. And if you see the QRS, total QRS height, AVR is nearly 1/3 elevated. That is too much. More than V1. Now, if you come across such ECGs with widespread depressions, that should make you suspect left main. Now, why these changes occur? See, when there is a left main disease, then almost all the areas are injured, right? But the current shifts upwards. A major current shows upwards. Why? Because the basal portion of the left ventricle is also involved because of the concurrent involvement of circumflex as well as LED. So the injured current looks upwards. That is why those leads which are facing upwards will be positive, and those are AVR and V1. Now, if it is upwards and right, that means the whole left ventricle is gone. If it is upwards and to the left, that means towards V1, then it is anterior portion of LV is gone, that is LED. So whenever you are faced with these elevations in these 2 leads, AVR and AVL, look whether AVR is more than V1 ST segment or ST segment elevation in V1 is more than AVR. In this patient, AVR is more than V1. So this is a very, very sinister ECG, which tells you that this patient is having a left main occlusion. These widespread ST segment changes, they can be considered as reciprocal changes. This next case. Again, option acute chest, 4 hours chest pain, middle-aged man. These are the options: proximal RCA, proximal LCX, Left main, LED or none? The time starts now. Let us see what are the answers now. This was question 6, I believe.
Yes.
Yes. The proximal RCA, majority believe it is proximal RCA. Yes. So once we are analyzing ECG, and ECG analysis starts with P wave, PR interval, QRS, QT, and one branch blocks duration in the systematic way. And once you start analyzing, you see P waves are not seen. P waves are not seen. That means the atria may be involved. If atria is involved, then it has to be either RCA or LCX. Can you see the P waves here? P waves are seen here, retrograde and inverted. So most likely it is a junction. If you see the ST segment is elevated in inferior leads, lead 3 to AVF. And then if you compare, lead 3 is more than lead 2. That helps us to come to a diagnosis of RCA. At the same time, if you start finding reciprocal ST segment depression in AVL, this almost always clinches the diagnosis to RCA. Now we have seen many of these ECGs. Let us see one more. And then we'll come to approach to a case, how 2-3 AVF diagnosis should be done. Look at this case. Time starts. I hope everybody will pick this up. 100%. Circumflex. Circumflex, proximal circumflex. Okay. So what is most striking in this? Most striking here is the rhythm. This rhythm is not sinus rhythm. There is some block going on. And the RR is not regular. RR is irregular. So if it is not sinus rhythm, it is a bradycardic rhythm. And if it had been a complete heart block, RR should have been regular. So this is type 2 block, some kind of type 2 block. Let us not go into this. This is a Wenke-Bach type of block. Now, which lead are ST elevations? The ST elevation is present in lead 2, 3, and AVF. And don't ignore V1. V1 is also elevated. If you can see here, V1 is also elevated. What about AVL? AVL is depressed, markedly depressed. What about lateral leads? Lateral leads are also elevated. So if you try to find out the area which is gone is inferior, lateral, and right ventricle. Most likely right ventricle, because V1 is elevated. So it is a proximal RCA. And added to this, a AV conduction abnormality. Remember, 90 to 95%, if there is a AV conduction abnormality, it has to be RCA. So since it is V1 which is showing the right ventricle, it is a large right coronary artery which is also supplying the posterolateral area, or that is what is called as the superdominant artery. If the ST segment elevations in V5, V6 are more than or equal to 3 millimeters, then it is a superdominant right coronary artery which is going posterior, extending beyond the crux and supplying the areas of the left circumflex, which are traditionally supplied by the left circumflex. So this is a proximal right coronary artery. Probably confusion was because of V2. However, presence of abnormal AV conduction or AV conduction block should clinch the diagnosis of inferior LMI because of RCA. So now, how do we approach this inferior? It appears quite, because there was some confusion in the last answer. Now, one has to see what are these. This is lead 1, this is lead 2, lead 3. Now, and this is the vector. Now, once there is a right coronary involvement, the infarction is here on the posterior basal aspect of the left ventricle. So the current of injury will be going towards this side, that will be towards lead 3. This represents lead 2 positive pole, this represents lead 3 axis, right? This is the axis of lead 3, this is the axis of lead 2, with the positivity being here. But since this is the inferolateral aspect, current will be on this side. So lead 3 will be more than lead 2 if it is a RCA infarction. And the sensitivity of specificity is very, very high. Along with this, since the vector is going away from AVL or lead 1 AVL will be depressed. This is again very sensitive. Now what happens? This is the posterior lateral area in circumflex, and the direction of vector is towards lead 2 because it is in this direction. Compare it with this picture. So this is lead 2. Lead 2 will be more than lead 3, and AVL may or may not be elevated. Now compare here. On the left is left circumflex ECG, and right side is RCA. If you see here, ST segment elevation in lead 2 is more than ST segment elevation or no ST segment elevation in lead 3. Besides this, you come to V1, V2, V3, and you see there are some depressions here that are favoring LCX. See on the right side of ECG, lead 2 hardly is showing ST elevation, lead 3 is showing ST elevation, along with reciprocal changes in AVL, right? And V4, V5 are ST segment elevation here also tells you that there is associated right ventricular infarction. So if you are faced with inferior situation, then look between lead 2, lead 3 ST segment elevation ratio and look at AVL to decide the diagnosis. As far as ST segment, so this can be another approach. ST segment elevation in inferior leads, how to go ahead? Go for ST depression in a lead 1 or AVL. If it is present, make it a right coronary artery disease. If it is not there, go for ST elevation in V5, V6, more than lead 3. If it is present, circumflex. If it is not there, go for ST segment depression in V3 versus ST segment elevation in lead 3. Read it more than 1, not 1.2, more than 1 is sufficient. So if it is there, then this will be left circumflex artery. What this all is telling is, that if lateral area or posterolateral area is involved, that is classically the circumflex direction. There's another case, again, 56-year-old man presenting with a history of chest pain for last 4 hours. Time starts now. The buzzer is also tired now. So now we come LED proximal. I think this is question 1, 2, 3, 4, 5, 6. Which question was it?
Question 8.
Question 8. Okay. 6, 7, and 8. This is LCX. Our question 8. This is LCX. Right. Let us see. Everybody said, yes, lead 2 is higher than lead 3. Absolutely correct. But there is something unusual. Lead 1 is elevated. How can the lead 1 be elevated? And probably the audience didn't see the whole ECG carefully. There is inverted P wave in lead 1. And the AVR is elevated upright and AVL is downright. And there is a reverse chest progression. Now the diagnosis becomes simple. This is a dextrocardia. Once you reverse the lead, what will happen? AVR will change into AVL. AVL will change into AVR. Lead 1 will become upright. And 2 and 3, lead 2 and lead 3 will change place. That is what happens in dextrocardia. Lead 3 and lead 2 will interchange their places. So what happened here? If you see, lead 2 was elevated, lead 3 was not that elevated, and AVR was depressed, AVL was not depressed. They interchange the places. So at that time also you could diagnose, but once you reverse the leads, you saw this lead 3 is elevated more than lead 2 and AVL is reversed. So the diagnosis now becomes RCA with dextrocardia. Okay. This is another case. Again, 46-year-old man presenting with a history of chest pain for 4 hours. Time starts now. I think half a minute is a bit lesser time because so many things have to be seen. This was question 9. So LED proximal 149. All 4 answers are there. 1/3 LCX, 1/4 RCA. Okay. We analyze this. So here is the patient. Almost all leads are elevated. ST elevation in all leads, anterior, inferior, all areas are injured. Lead 1 is also lead 2, lead 3, AVL, AVF, V1, V2, V3, V4. How can it possible? All areas are injured. It is not possible. An ST depression only in the cavity lead, that again is difficult to explain. So all areas of the left ventricle, the current of injury going to all areas, anterior also, lateral also, inferior also, posterior also, it can only be possible if all are inflamed or injured simultaneously. And the only condition can be a pericarditis or myopericarditis. The ECG changes in pericarditis are because of myopericarditis or some inflammation of the myocardium. So that can be the only situation when all the leads are showing the current of injury. And then where would the reciprocal change be? Reciprocal change will be away from all the leads. That means towards the cavity. And which lead is looking to the cavity? The only lead looking to the cavity is the AVR, which is looking from your right shoulder. It is looking into the cavity. So all areas are elevated. Only the AVR is depressed. The diagnosis is pericarditis. So in this case, none of the arteries, this patient also underwent angiogram. And as predicted, and he was taken by the residents for emergency angiogram. Nothing was found abnormal. They thought that they have picked up the patient very early, very early. They did the angiogram, nothing was there, and they made a diagnosis that probably we have done it so early that the clot is not there, it is gone. However, later on when the ECG did not evolve, a diagnosis of pericarditis was made. Remember, in pericarditis, there may be no other routine investigational findings. Troponin T may be mildly elevated, which might say that it is myocardial involvement. However, pericardial effusion may not be seen in echocardiography. So the procedure, or let's say the investigation of routine investigation of choice here is only the ECG. Here is another case, a 42-year-old male patient with diabetes, presents with history of palpitation and dizziness with chest discomfort. Two similar episodes in past. And this was a prolonged pain that he came with. These are the possibilities: AF with inferior MI, polymorphic VT, atrial fibrillation with pre-excitation, or these artifacts. Time starts now. Okay. So it is A, B, C, inferior wall, polymorphic, AF, artifacts, everything is there. Let's go back. So this is the patient. Now it is very clear, 2, 3 and AVF are having QS pattern, Q waves. But there is something very unusual. If you see the RR, shortest RR interval, it is 5 small squares. That means the rate is somewhere around 250, 300. No, this cannot be a simple inferior wall, because this conduction then will be considered through the AV node, and AV node cannot conduct at that rate. So it is not atrial fibrillation with inferior MI. It is too fast for that. But this broad and irregular, can this be a polymorphic VT? Unlikely, because in polymorphic VT, remember, no two beats are similar. No two beats are similar. See here. And see, in a given lead, all beats are similar. So this is not a polymorphic VT as well. Now, patient was cardioverted because he was hypotensive. Now, does this help? Yes. Once you cardioverted, you saw delta waves here. Also in 2,3 AVF, V45, V6. So diagnosis now becomes atrial fibrillation. This is a pre-excitation and atrial fibrillation with pre-excitation. Just a word, long-term treatment cannot be AV nodal blockers, because more and more atrial fibrillation can be conducted to ventricle straight away, may produce VT. Drugs which can help here is procainamide. But in this patient, radio frequency ablation and termination, or let's say ablation of this pathway, is a must. So here, the rate shortest RR interval of 250 seconds tells us that this patient is a high risk for VF also. So next time, whenever you are seeing fast, broad, irregular, irrespective of the Q waves, look at the heart rate. If it is very rapid, it is wide, fast, broad, irregular, consider AF with accessory pathway. And this is another patient, quick patient, 28-year-old male, juvenile diabetes, presents with angina with moderate dyspnea. Proximal LED, LCX, left main, none. I think I'll keep this the last question. Time starts now. No. The buzzer. The 11th answer is Left main, 75%. Yes. Let's go. So that is what actually happened to the patient. He was immediately taken up with the ECG. Why? Because was elevated. AVR was more than V1. All other areas were depressed, markedly depressed. A diagnosis of left main was considered. He was immediately taken to the cath lab with the HbA/AG and HIV and all that routinely done. Troponin even was not done, and the coronary arteries were normal, absolutely normal. Then the resident came running and he said that, sir, the hemoglobin is 3 grams. So now this is AVR ST elevation, other leads depression syndrome. In a situation of severe anemia, severe hypovolemia, hypotension, severe hypoglycemia, hypoxia, or metabolic acidosis, the whole myocardium suffers. And that gives rise to a similar picture as if left main is occluded. So if you exclude this, then it is a left main occlusion. Otherwise, these things have to be ruled out quickly, clinically, when we are coming to a diagnosis of. I think I will stop here.
Yeah, thank you, sir. That was really last one was a googly from Charles, like a Charles bowling. It was deadly for. I'm sure all our best men were out in that band. It was a fantastic learning, especially for coronary artery localization, infarct related artery. And probably what I suspect or I see that most of our physician friends will start seeing you ECGs and they said, why send patient for a coronary angiography? Let's do the localization from Dr. Dwivedi sir itself. At least we know.
Harm the fraternity.
So it is going to be the diagnostic angiography from Dr. Dwivedi sir. So that was a fantastic presentation and a learning for all of us. And I'm sure all of our delegates have really thoroughly enjoyed and took some definitely take home message in this session also. We would be thankful to all our participants. I would be thankful to our MMC observer, Dr. Arvind Gongane, who was there as a MMC observer for the credit points. Again, a reminder to all the delegates, those who have not filled in their data for MMC registration, please do fill in over there, because we are going to have this series of sessions. I will just share it once also. We are going to have the series of sessions in every Sunday. This was the first session which we had. We are going to have next session on 8th November, where diagnostic modalities in cardiology will be there. We will have third session on 22nd November, because 15th November is a new year. So 22nd November, we'll have a session on hypertension. And on 29th November, we will have cardiology in pregnancy. And in each module, we are going to have a ECG quiz by the quiz master, which is going to be definitely give you a take home messages on everyone. I also request all those who are not a member of Indian Society of Electrocardiology, please make it a point, visit our website www.iacindia.org. You can download the membership form and can fill it and send to our official address, which all the details have been there. And definitely it will be a point you will feel the benefit of becoming a member over here. So thank you so much to all our faculties, including Dr. Dwivedi sir, for sparing their valuable time. And before I hand over, I would be obviously fail if I say that all this has been possible with unrestricted educational grant coming from Zydus Cadila. So I am thankful to obviously Mr. Kamath, Mr. Gautam Ghosh, Mr. Jainesh Patel, and Dr. Samir Muchala for sparing their valuable time and giving unrestricted educational grant to IAC. And for the final vote of thanks, I would hand over to Dr. Samir Muchala, head medical team from Zydus. Dr. Samir, please.
Thanks, Dr. Ketan Mehta. I think we had great deliberations today on diagnosis of ischemic heart disease. My heartfelt thanks goes to Dr. S.B. Gupta, Dr. Darshan Jala, and Dr. Mona Bhatia for effective deliberations on the role of stress test, 2D echo, and CT angio respectively in the diagnosis of IHD. My thanks also goes to Dr. G.R. Kane, who moderated the discussion in a way that key messages were percolated to our esteemed delegates. Dr. S.K. Dwivedi always has been fabulous in his ECG quiz, and today also, as before, all the delegates were hooked up and actively engaged in this ECG quiz. Thank you very much. Last but not the least, my thank goes to Dr. Ketan Mehta, Honorary General Secretary, Indian Society of Electrocardiology, for unraveling this unique concept of common cardiology care for clinicians, popularly will be known as C4, which has a touch of innovation. I'm happy to share that we had 610 delegates pan India who have witnessed this webinar. I thank you all for sparing your precious time on a Sunday morning and also, as always, supporting our Indian patients during this COVID scare. We all will meet again next Sunday, November 8th, at the same time for another high decibel discussion on different modalities, diagnostic modalities, and cardiology. Till then, let us all stay safe, stay healthy, and let us all have a great Sunday. Thank you very much.
Thank you, sir.
Thank you.
Thank you.